Yeah, good morning, everyone. I'm Bhushan Sabnis from Mumbai. I'm a knee surgeon. I don't have any disclosures. I was going to make it on a lighter note, but realizing this is ROC is going to be a serious thing. I was going to put a picture of a OATs Quaker man being kicked by Lionel Messi, but thought otherwise. I think it's sensible to keep it a bit sensible. So let's start. We know that cartilage has a very specific anatomy, and the key word here is the type 2 collagen fibers. Now, importantly, 90% of the proteoglycan matrix is embedded in this specific meshwork of collagen type 2 fibers, and which gives the cartilage resistance to loading. Now, if there's ever a break in the calcified layer of cartilage, you get the stem cells or mesenchymal cells coming from the bone marrow, and this usually leads to development of type 1 collagen, i.e. development of fibrocartilage. Now, why are we talking about OATs and MACI? It's a simple fact that the chondral lesions do not heal. Microfracture does give a decent functional recovery in low demand patients, but we are talking about young people who have the whole life in front of them. So going back, let's say, a couple of centuries back, to 250 years back, it was William Hunter, the famous surgeon from London and Edinburgh, who actually wrote specific words about cartilage in his essay on About Articular Cartilage, which says that ulcerated cartilage is a troublesome thing, and once destroyed, it is not repaired. And this still holds true. So we know that cartilage, if damaged, does not recover or does not come back to normal. Now, let's roll over about 200 odd years, and in 1941, it was Magnuson who started the concept of abrasion chondroplasty, where everything was just debrided all the way to subchondral bone, and you allow the subchondral bone to give fibrocartilage, which forms a decent cover. This was followed by Priddy and Steadman in 1990, where the concept of microfracture came in, and which still holds true. We are still using the arthroscopic awls that were devised by Steadman in 1990, and we are still using exactly the same procedure of arthroscopic microfracture for treating chondral lesions. Now, beyond this, the research seems to have split into various directions. Osteochondral grafts, chondrocyte transplants, and artificial scaffolds came into vogue. Now, this is something known as chondroglide, which is also known as microfracture plus, where a microfracture is done and just a collagen scaffold is placed on top. Now, the history of ACI is quite interesting. In 1971, Brentley and Gear published their work on rabbits, and this led to an interest in actual transplanting chondrocytes to get healing of cartilage. And indeed, 87, it was introduced in humans, and then the first paper came out from Bridberg in 1994. And the procedure described still holds true. That's exactly how we're still doing the first generation ACI, where we harvest a normal chondral tissue, get the chondrocytes, culture them, grow them in a lab, put them in a test tube, transport it back to the theater, and in a few weeks' time, we do a second surgery where we instill that under a periosteal patch. This was largely called as the first generation of ACI. The main problem of using a periosteal patch was a morbidity. You had to take some periosteum from the proximal tibia. Number two was that patch tended to ossify and tended to undergo hypertrophy. And about 20% of patients required a second surgery to take out that hypertrophied part. This led to the development of the second generation of AC, where instead of a periosteal patch, we started using standardized collagen membrane, which was either a natural one, porcine one, or a synthetic one. This was later improved to include collagen scaffolds, and this study actually showed really good results in second generation ACI as compared to first generation ACI. The third generation is what we are looking at now. MACI or MACT is matrix augmented, associated, or induced autologous cartilage instillation, implant, or transplant. The literature is full of a lot of different variations in names for this procedure as such. Now, essential important thing of MACI is that the collagen membrane is actually seeded or layered with the chondrocytes which are grown in the lab. So this gives an even distribution of the chondrocytes on the patch that you're using. It makes the handling very easy, and it easily allows us to tackle shallow defects of chondral lesions. The basic steps remain the same: harvest and culture of chondrocytes. In the second stage of MACI, you can do it either open or arthroscopic. The defect is actually templated using an aluminum foil template or any other stiff template. The MACI scaffold is placed cell up, and then it's cut to shape, and with a fibrin glue, as glue is simply stuck onto the defect, which is prepared dry and bloodless. Now, no microfracture is done. This is very important to know in this thing. So the main advantage of MACI over the previous generation, apart from the even distribution of chondrocytes, is there is no need for suturing, and there is no need for doing a watertight closure in any way. The next generation has already come in now, where now we are using the various collagen scaffolds, the so-called 3D matrix scaffolds, in which the cells are actually suspended, and that gives even better handling properties, and the results are quite good in the early term and quite encouraging. The image that you see on the right side is actually of something called a SCART patch or CART patch, which is alginate agarose matrix with suspended cells, and this is normally used now. What about the results? I said the results are conflicting. So these generations of ACI, P, ACI, C, and MACI, that's how we call 3 generations of autologous chondrocyte implantation, unfortunately hasn't stood true in terms of literature references, and I can quote about 10 or 11 studies which actually show no difference in the results with ACIP or MACI. So the results are quite confusing. A Cochrane database actually still states that because of a lack of RCTs, it's difficult to recommend ACI over microfracture. So we are still not sure in terms of literature and evidence for using ACI over anything else. Now, unfortunately, most of the studies when you look at are comparing ACI or OATs with microfracture. And there is definite paucity of literature comparing the two between themselves. Now, add to that, most of the literature is in the form of case series. Now, in this UK systematic review, both MACI and ACIP were found to be superior to MF or microfracture in short or intermediate term. We know that both of them work better than microfracture. Let's go a bit differently. What about autologous tissue transplant? Now, the main reason why this field is very attractive is that we know chondrocytes are very delicate, and it's been shown that even a slight change in the pH of the medium makes chondrocytes turn into fibrocytes. The aim of treating any chondral lesion is regeneration of hyaline cartilage. Transplanting osteochondral cylinders or dovels is hence pretty attractive because you're changing like for like, and this is how mosaic-plasty came into vogue. Now, mosaic-plasty included using multiple small cylinders or dovels of osteochondral segments and then packing them in the prepared defect to get a good cover. Now, people went overboard with that, and this one has actually 23 dovels stuck in there. The main issue is that the osteochondral defects heal by fibrocartilage between the grafts. So if you look at that picture or the picture before, about 50% of the lesion is going to be covered with hyaline cartilage, but 50% is going to be covered with fibrocartilage. Now, this is how the OATs system came into vogue. Again, OATs is more of a company name. There are a lot of other names around. You can call it OCT, you can call AOT, or there are a lot of names around for that. So logically, if you use a larger dowel of osteochondral cylinder, then you can cover more area of the same defect, and this can help you in covering the defect significantly more with hyaline cartilage as compared to fibrocartilage. Now, there is also a kit for something known as mega OATs, where actually you can take up to 30 millimeters of osteochondral dowel, usually from the posterior femoral condyle, and implant it over the defect to cover it. And that is a very renowned technique by Professor Imhoff about it. Now, this is one of my patients. Doesn't look very good, I agree, but 1.5 years down the line, he's still one of my happiest patients from OATs. So this guy had a central defect in a flat trochlea, which was rubbing on his patella in normal activities, and he was always unhappy with his knee, and now he's gone back to playing squash. So OATs procedure per se can be open or arthroscopic. It essentially involves measuring the diameter of the defect, preparing the defect, taking an osteochondral dowel such as this, and then implanting it into the defect which is already prepared, and gently tapping it. Now, one caution, one important thing to remember is not to tap it vigorously, but to tap it very gently, because it's been shown the impact is something which will kill the chondrocytes straight away. What about the results for OATs? Now, as I said, there are a lot of names in the literature. So in the first study, you can see it's called OCT. So and most of the studies are actually looking at mosaic plasty, because OATs is a fairly new thing. So this Austrian study shows excellent results in short term. There is a gradual deterioration up to 7 years, but good function ultimately at 10 years. Now, there is a specific protocol which is used to measure the chondral structure using MRI. That's called as MOCART. MOCART stands for Magnetic Resonance Observed Cartilage Regenerate Tissue Assessment. And there is a variant of that known as 3D MOCART. And using both of these studies, we have seen that the cartilage cover that happens after OATs is significantly near normal. Now, mark my words, near normal. We have never gone back to normal yet. This study from Illinois, USA actually shows that in a slightly older population, the average age was 44. In them, after about 45 months of follow-up, when they did biopsy of some patients, they found hyaline cartilage instead of fibrocartilage, which actually proves the point for OATs. I can keep on quoting references for various things. The Gouda study in 2005 actually proves the OATs is very significantly better in terms of results as compared to microfracture. This study from Netherlands also proves the same thing. They call it OMAT for some reason, so there's a lot of names and confusion. Now, what to do with subchondral bone? The main issue that we now know is the importance of subchondral bone. If you have abnormal subchondral bone, then any procedure you do on top for cartilage regeneration is not going to work. So in simple words, if subchondral bone is good, then you can attempt cartilage repair. If subchondral bone is bad, you need to replace the whole thing. Is it true? So there are a lot of studies now on using MACI for deeper defects. So MACI is usually normally done for defects less than 8 millimeters, but there are a lot of studies now which show MACI can be done in deeper defects. This is a study from Oswestry, which actually shows a procedure where unicortical autologous bone graft followed by cancellous bone grafting and then followed by MACI. The so-called OSPLUG technique usually gives a brilliant results at 5 years. So that's a good way of managing things. Mosaic plasty per itself has a brilliant result. Now, there is a definite difference between femur and patella chondral lesions. If you listen to Deepak's talk, the femoral lesions do well, followed by tibial lesions, and the last are the patellar lesions. And there are quite a few papers around in literature which state that you should not do MACI or OATs in patella. But there are a lot of studies which actually shows that MACI or OATs do work well in patellar lesions also. Now, the main thing we need to know is which is better, MACI or OATs. As I said, there are very few studies around. Most of them are actually looking at ACI and comparing it with mosaic plasty, whose results were slightly poor. Now, this is a meta-analysis. The first one is a meta-analysis from Ohio, where the results were almost the same at 2 years follow-up, or 2 and 5 years follow-up, but hyaline cartilage was present in ACI, so in OATs, and normal cartilage was seen in MACI. Now, there are various management options for chondral defects, as we know, right from non-surgical to going all the way to the 3 generations of ACI. The main differences between MACI and OATs for you to remember is that MACI is a two-stage procedure. It requires 6 weeks break in between, 30 seconds more. You can cover larger defects with MACI, and with the newer techniques, you can even cover larger, deeper defects as well. OATs, however, the single surgery can cover up to 4 centimeters square of defect. The limitation for OATs is a donor site availability, and deep lesions can be easily managed. The important part to remember is not to miss out. The first thing to correct is to get your alignment right, to get the knee stabilized, and correct the meniscal pathology before embarking on any of these techniques. I am slightly biased towards OATs because of one thing I practice in India. The first thing is cost. Second thing is a one-stage procedure. I am actually changing hyaline cartilage for hyaline cartilage. I can easily manage the subchondral bony cysts or defects. You can go up to 20 millimeters of a dowel if you need to replace. Then the results are, I think, generally the same in short and mid-term. So if you ask for my opinion, in a stable or stabilized, well-aligned, either surgically or naturally well-aligned knee, in a young, active, high-demand patient with a complete chondral defect of size less than 2.5 centimeters, I would go for OATs. Slightly younger patient with good subchondral bone and a larger defect, I would go for MACI. Now, important thing to remember is you can revise MACI to OATs, but not other way around. Now, are we winning this battle? I don't think so, but I think we are on the right track with both of these. Now, this is an algorithm I tend to follow. It just exactly says everything I've said. And lastly, to sum it up, there's an excellent paper by Brian Cole from Chicago, and it just says it's important to tailor your treatment according to the patient needs and the nature of the chondral defect that the patient has. If you're treating a high-level sportsman, it's been found that microfracture still gets them back to field very early, while OATs and MACI take a longer time. So you have to decide the treatment based on the patient and the defect that you're dealing with. Thank you. I would also like to invite you all to the first Mumbai osteotomy course on 10th of March 2018. Thank you.